funded, including large projects, knowledge synthesis, policy analysis, and training awards, all aimed at addressing priority areas that were priorities for health policymakers and decision makers. So far, CIHR has spent approximately $6.5 million on these leading projects, and our hope is to share the results of these through the policy round. An integrated knowledge translation approach was used for CIHR initiatives, and that ensured that knowledge users, the people who actually needed to use this knowledge to make decisions, in fact, were driving the bus, determining what was a high priority to be addressed. And so I think you'll find these rounds relevant and timely. For our first rounds, we have partnered with the Ministry of Health in British Columbia, the Michael Smith Foundation, and CIHR. I'm thrilled actually to work with these fabulous partners in introducing, I think, a very fascinating topic for our first policy round. In sum, actually, the objectives for this policy round are to learn about the important characteristics of patient-reported outcome measure instruments, to inform decisions about which of these to use, to understand the evidence related to measuring patient health outcomes through PROMs, to recognize the important opportunities and challenges regarding routine integration and utilization of PROMs in the healthcare system. I'd like to quickly outline the day. I'll be introducing the speakers, and they'll be presenting their research results. They'll be presenting the policy implications of those research results, and then we will be opening it up for discussion. At any time during the round, I want to encourage you to identify 4 who would like to see come forward in future policy rounds. We'll be keeping track of those, and we'll be including in the portfolio and finding key researcher knowledge users who could present in this area. So for a quick survey, we'd like to get a sense of who's joined us for today's webinar. A short poll will appear on your screen. Could you please answer the following 2 questions? The first question is, how would you categorize your role or position? I don't think we have none of the above, but if you could actually try your best to put yourself into one of these categories. So you're a policy maker in some form or level in the health system, at the district region level or at the healthcare institution level or a community-based organization, or of a health provider organization, a student, a researcher in a university, a researcher in applied health settings, a consumer, or something else. So you can use the chat function to tell us your role. The second question we're asking you is just to give us an idea of which geographic region you're located in. So if you could proceed to answer those 2 questions, we can move on, and I'm thrilled to be able to present the speakers for today. While you're busy doing that, I want to present our 3 speakers. The first speaker is Dr. Sterling Bryant. Dr. Bryant is an economist with a long-standing and illustrious career specializing in healthcare. He has had extensive involvement with the United Kingdom National Institute for Health and Clinical Excellence, NICE, as many of us fondly refer to it as. For many years, he led the University of Birmingham team that conducted economic analysis for NICE, and subsequently served for 3 years as a member of the NICE Technology Appraisals Committee, advising on national coverage policy. In 2005, he was awarded the Commonwealth Fund Harkness Fellowship at the University researching technology coverage decision-making in U.S. healthcare organizations. We're pleased to say he moved to Canada in 2008 and joined the School of Public Health at UBC. He's the director for the Center for Clinical Epidemiology and Evaluation and at the Vancouver Coastal Health Research Institute, where he continues to focus on policy-relevant research. Our second speaker is Dr. Rick Zatowski. He holds a Canadian Research Chair on Patient-Reported Outcomes at the School of Nursing of Trinity Western University, and he is a research scientist with the Center for Health Evaluation and Outcome Sciences at Providence Healthcare in British Columbia. His program of research focuses on the validation patient-reported outcome measures in various healthcare contexts, including those for people with chronic life-limiting illnesses. And finally, and most importantly, Barbara Korobek. She is the Assistant Deputy Minister of Health Authorities of the Health Authorities Division, British Columbia Ministry of Health. Barbara was appointed in this role in April 2012. Prior to this, she was the Vice President of Clinical Operations at the Fraser Health Authority, where she provided executive leadership and strategic oversight to a range of integrated community acute care programs designed to improve health system capacity and foster population health focus to help sustain. Barbara has 30 years of experience in management positions in a variety of complex health environments, and she has more than a decade of experience with the BC Cancer Agency. Barbara holds a Master's in Nursing Health Administration stream from the University of British Columbia and a Bachelor of Science in Nursing from the University of Alberta. I'd like to also welcome the BC Ministry of Health. As I mentioned earlier, the research results we will be hearing about today arise from an expedited knowledge synthesis funded by a policy question identified by the BC Ministry of Health. I'm going to turn things over to Barbara now to provide some context for this work.
Hi, Barbara. You may go ahead.
Okay, thank you. In BC about 2 years ago, we just started to launch PROMS without really much planning or foresight, but that's kind of how things just sort of start sometimes. And from that, it was very valuable to be able to understand, to be able to say that we need to understand more about how PROMS fits in the whole evaluation mode, how it fits into planning of different services. So we did start, and we looked at surgery for hip and knee placement and shoulder surgery.
Hi, Barbara. Sorry, this is Chad speaking. Is it possible for you to speak a little louder?
Okay, I have the mic right in front of my...
Yeah, this is better.
Is that okay?
Thank you.
So I'll just back up a bit. So about 2 years ago, in the province of BC, we just decided to launch PROMS. And we hadn't done much provincial planning in that sector, but just thought to get going. From that, it's been a very valuable learning journey in that now we understand more the value of it, and also then how do we look at understanding more to understand how it's going to fit within our planning context and start to make policy around that. So the areas that we did start on was we started around hip and knee replacements and shoulder surgery. From that, we were able to, and why starting there was that from the frontline clinician's point of view, we got extreme buy-in from surgeries, from the surgeons, anesthetists, and all the rest of that to look at that. So we're already using some of that data. The next group that we started to move into was the integration of primary and community care, and that's the one that really started us to say we need to look at this more from a rigorous standpoint because we need specific tools and different things like that. So from a province of BC, we're quite committed to using PROMS. We have a lot of work that we need to understand around how do we link together all patient-centered sort of outcome data, and we can talk about that later on in the presentation. So I think I'll stop there because there's more valuable knowledge coming.
Thank you, Barbara. Sterling, you may go ahead now.
Okay, have I got control of the slides?
I will give you the power right away.
Okay. Great. So thank you for the invitation to present the work that we did with the ministry. Sorry, I'm just trying to work out how do I progress this slide.
You can just click the arrows at the top.
Got it. Right. Okay. Thank you. Sorry. So the project that we undertook was looking at patient-reported outcomes in the context of the integrated primary and community care initiative that was going forward in British Columbia. And what we were asked to do. This was a piece of work that was done in collaboration with colleagues from the Centre for Health Services and Policy Research at UBC, as well as CHAOS and the Centre for Clinical Epidemiology and Evaluation. So in terms of the work, what we're going to do is first of all provide you with a brief background on PROMS, and Rick, my colleague Rick Sawatsky, will provide that, and then I'll come back and talk a bit more about the objectives of the project specifically, and also the methods that we use to undertake this project. So I'll pass over now to Rick, and we'll just have a brief background and introduction to patient-reported outcomes.
Yes, thanks, Sterling. So we'll keep it brief here, and presumably most of us are quite familiar with patient-reported outcomes measures. But just to remind ourselves that we're focusing on the type of instruments that are used to obtain patients or healthcare recipients' appraisals of their health outcomes that are relevant to their quality of life in a fairly general sense. And the other thing to keep in mind is that we have tools to measure these things, and to keep in mind that these tools are typically multidimensional in nature, and that they assess various domains of human experience that are, in a general sense, relevant to quality of life or health-related quality of life. And so these domains, we're all familiar with them, I think, include symptoms, functional status, and various domains of well-being, like the psychosocial, as well as the spiritual in some of the instruments. And so the emphasis here is on patients' perspectives, and the ultimate goal is to get a patient's perspectives here without any interpretation by anybody else. So direct perspectives from patients. That's not always possible, for instance, in cases where the instrument needs to be indirectly administered, but that is the ultimate goal. So in the end, we did have to, for our particular project, make some differentiation in terms of the type of patient-reported outcomes measures we were interested in. And this was in negotiation with the ministry. And it was felt important to distinguish PREMS from PROMS. Now, PREMS are not as widely talked about quite yet in that particular form, but we're referring to PREMS as patient-reported experience measures that have more to do with satisfaction with care and satisfaction with the experience of the care delivery. The focus in this particular project is on PROMS, patient-reported outcome measures, so patients' appraisals of themselves. So what do the PROMS then measure? Well, there's several different classification systems out there. The ICF, International Classification of Functioning by the WHO, is the one that's very well known. Here we're giving one that just gives that was put forward by the NIH, Patient-Reported Outcomes Measurement Information System, which is very elaborate, and this is just a snapshot of their very general domains. They have a lengthy framework related to this, and I encourage you to have a look if you're interested. So in general, they classified it in terms of physical, mental, and social health, which is a quite generic classification. And then there's domains, kind of generic domains that are applicable across a wide range of applications in the first row there, and then additional domains that have more specific applicability. So that's just as a kind of to give us a sense of what is being measured. Next slide. The other question is, how are PROMS being used? And it is important to pay attention to the purposes of collecting patient-reported outcomes information. This is particularly important when selecting a patient-reported outcomes instrument. Some instruments provide information that is, for instance, more useful or suitable for clinical application, so to inform the purposes of healthcare professionals in making treatment decisions and monitoring patients' conditions, whereas other instruments are more applicable or suitable for higher-level administrative decision-making or outcomes evaluation, such as for health researchers examining the effectiveness of treatments or interventions, and health service decision-makers, such as for for program evaluation and those kind of purposes. And the ultimate goal is, of course, to find instruments that cut across these different types of purposes, but keeping in mind that different instruments do preference different types of audiences or stakeholders. It is also important to keep in mind that there is quite a diversity in patient-reported outcomes instruments. The ProQOL-ID database, which is a database by the Mappy Institute of patient-reported outcome measures that you can access online, last time I checked included 747 instruments. There may be even a bit more by now. So there's quite a few instruments out there, and they're generally classified in terms of generic PROMs that are those that are applicable at a kind of a population level and cut across different conditions, and disease-specific PROMs that are tailored measures, tailored to the health outcomes relevant to particular disease processes or disease manifestations. And of course, considering the diversity of instruments, there's also an enormous diversity of items, the type of questions that are being asked to measure these patient-reported outcomes. And it is important for us to be mindful of that when selecting an instrument, that we're not only looking at kind of the psychometric and the characteristics of the instrument, but also looking at the items themselves. Do those items actually make sense to our population? Are people going to be interpreting them in a way that is meaningful to us and to them? So next slide. And then besides diversity in instruments, there's also great diversity in healthcare populations, and we need to be mindful of that. And so this, of course, includes diversity in terms of different healthcare contexts and different healthcare differences in health status, different conditions, but also includes diversity in terms of cultural diversity and different social demographic characteristics. All of these things may influence how people interpret and respond to the questions, and so we need to be mindful of that. Next slide. So thinking of these past slides, we've kind of summarized the challenges in PRO's measurements, the most significant ones, what we found to be the most significant ones in the following slide. One challenge, and these are not insurmountable challenges, but they are things that we need to be mindful of. One has to do with validation, and of course that is a significant focus of the project, is to gather evidence on validation. So validity and reliability of the scores. And there's basically two challenges in that. One is, from the previous slide, the heterogeneity in the population. People may not be interpreting the questions in the same way. And so there may be factors other than that which we're trying to measure that influence people's responses in different ways. And we need to find ways of accommodating those factors, because if we do not, then it threatens the comparability of scores across different individuals or groups of people with different backgrounds. So that's the challenge of population heterogeneity. And then there's a challenge of response shift, and there's a lot of work being done in that area as well. And that has to do with the situation where an individual's frame of reference may change in response to a health event or an intervention. So it has to do with the comparability of scores within individuals over time, which may change. So a person before and after a surgery may actually interpret the question differently because their frame of reference has changed, or before and after a significant health event. So that has to do with the repeated measures type of use of patient-reported outcomes measurements. And all the technical validity and reliability approaches can be classified in relation to these general categories of validation. But there's also practical considerations, such as patient burden. And so these instruments could become very long, so they tend to pile up. And so there's very much a need for short instruments, because people get frustrated if they receive get long list of questions and perceive the questions as being either repetitive or not very applicable to their particular circumstance. And so one development in that area is the development of computerized adaptive tests, which we're not going to talk about much today, but just wanting you to be alert to that, and that there are testing systems in which items are selected and administered to be most relevant to particular groups of particular people. And so those are the computerized adaptive testing systems. And then finally, there's the challenges of utilization and the routine integration of PROMs in healthcare. And that's much of what this project is about. So it has to do with how do we select appropriate PROMs instruments? How do we actually integrate this into the workflow of healthcare professionals or the lives of patients who are ultimately going to be providing us the information? And then what are the approaches for the analysis and the utilization of PROMs information?
Great, thanks very much, Rick. So back to me. So I'm going to just talk about the project objectives and the methods, and then give you a few results, and then Rick's going to talk a bit more about the results later. So the project objective was to explore the utility of existing generic instruments. So it's important that we emphasize the generic part. So we were asked by the ministry not to look at condition-specific instruments, but to look at generic instruments, because this project was being conducted in the context of evaluation of primary and community care initiatives that were going forward in British Columbia. So we were tasked with looking at what existing generic instruments are there, and which ones might be most suitable in the context of reform initiatives focusing on primary improvements of primary and community healthcare. So our project had a number of components. So we started off by trying to produce a reasonably comprehensive long list of all potential generic PROM instruments from which we would then make our selection. So our task was to try and come up with a recommendation on a particular PROM instrument or a set of PROM instruments that could be used for the evaluation of integrated primary and community care. So we got a long list. We then tried to reduce that to a shorter list by focusing on those instruments that were clearly self-report, that were truly generic and were not considering condition-specific aspects, that were true assessments of quality of life. So we wanted to exclude those instruments that were focusing on experience and satisfaction, and that they were developed for an adult population. So there's quite a lot of instruments that have been developed focusing on pediatric and child populations. We wanted this to be on an adult population. And we reduced that to a shorter list, also looking at the citation count. So our thinking there was we want to know which instruments are currently being used, where is the literature at in terms of the current use of instruments. So we wanted to make sure that we were conscious of the sort of current use issue as well. Once we'd got down to a shorter list of instruments, then we looked at the characteristics of those that short list. So we were looking at things like the translations that were available, the burden, as Rick has indicated, in terms of literacy and reading level, the cost of using the instrument, and also the dimension coverage. So which instruments were covering with dimensions of quality of life that we thought were important in the particular context of primary care. We then did a review of reviews looking at the performance of the instruments. So we looked at both the psychometric performance in terms of validity and reliability, but we also looked at the instrument's performance in terms of decision-making attributes. So for example, were there norm reference sets available? Were there utility or preference scoring algorithms available? And were there clinically relevant thresholds for these instruments? So we'll present results on each of those things. We then looked for some additional information in terms of the use of these instruments in other jurisdictions in Canada. And then we finished up with a workshop where we engaged with our partners at the ministry, at Michael Smith, and also within the healthcare system in British Columbia to present our results and identify a preferred instrument. So we're going to run through the work we did and provide you with some results. So the search, this was the search for our PROM instruments to get a long and then a shorter list of instruments. So we looked at review articles. There are some really good websites. Rick's already mentioned the ProQOL-ID website, which is run by the MAPI Institute. So that provided a lot of useful information. So we searched widely. We came up with 115 generic instruments from that broad web-based search. We wanted to make sure that the RAND instruments were on the radar, the PROMIS instrument that's been developed by NIH, and also there's interest in BC in an instrument called How's Your Health that has been developed in the US, and so we wanted to make sure that those were part of what we were looking at. So we ended up with 46 instruments. We then did a citation search on those instruments, and then reduced the instruments down to 9. Broad categories of instruments that we then looked at in more detail. Okay, so this is just give you an idea of the sort of citation count that we did for the instruments. So these are on the left-hand side, we have the instruments that we have listed as our shortlisted instruments. So we have an AQOL, EQ5D. We've got the SF. We described it as the SF family, so we've got the SF36 and the SF12, the Health Utilities Index, the Nottingham Health Profile, the Quality of Wellbeing Scale, and we've focused on the self-administered version of that, and the WHO Quality of Life instrument, and they have a brief version of that, and we focused on that. So all of these instruments exist in the literature and have been widely cited. But we then also looked at those that have been more recently cited, and the EQ5D and the SF instruments were the most cited more recently. We don't have the PROMIS instrument on this list, and we did include that instrument, and that was simply because the literature searching for the word PROMIS was problematic, and so we couldn't specify that instrument, and it's a more recent instrument anyway, but we certainly did include that as well. Okay, so I'm just going to give you a few of the descriptives on these instruments. So we're going to start off with burden. So this is one of the characteristics that we wanted to have information on to inform selection. So which of these instruments represent the least burden for patients when they're completing them. And what you'll see is that the EQ5D, the SF12, and the PROMIS instruments have the fewest number of smallest number of questions and take the least time to complete. So that was one aspect of burden. But then the second aspect of burden was to do with readability. So we actually calculated a reading ease score and also a reading grade score. And these are scores that are easy to calculate just using the text that we have from the instrument. And you'll see that the reading ease score, the readability scores were most favorable for the AQOL. So the E score was quite high, so that indicates that it's in a positive sense, it's an easier instrument to read, and that the grade score is 5.3. So that's saying that someone who's got an education that goes just beyond grade 5 should be able to read that instrument. So those that were most favorable were the AQOL, the SF36, and the Quality of Wellbeing Scale. And interestingly, those that were not so promising from a readability score were the EQ5D, and then also the Health Utilities Index and PROMIS, which was surprising, but it's interesting when you actually start looking at some of the language that's used in some of the instruments, then you can understand those reading score results. Another thing that we wanted to make sure that we had a good picture of was the domains that were being covered by the instruments. So what we did was simply to classify each instrument in terms of the items that were included in the instruments, and classify those items in terms of whether they were relating to a social health issue, a mental health issue, a physical health issue that related to functioning, a physical health issue that related to symptoms, or a general health issue. And we were thinking that a better instrument would be including all of these domains of health-related quality of life. So these are the graphically presented are the results that we found. So we see some variability in terms of the coverage of various domains across the instrument. So for example, if we look at the Health Utilities Index, then that's largely focusing on health, physical health symptoms, physical health function, and mental health, whereas something like PROMIS, for example, is covering the full range. It's got a general health issue as well as social, mental and physical health characteristics or domains being covered, and we see quite a wide variety of or variation, I should say, in terms of the domain coverage across the instruments. In terms of the cost of using these instruments, then most of the instruments that we have on our shortlist are freely available for use, especially in research settings. The exceptions to that are the SF family. So there's a user fee to use the SF12 and the SF36, certainly version 2. But there are, and we'll maybe talk about this a bit later, but there are alternative versions that the RAND Institute and the Veterans Administration have developed that are then freely available for use, but they are slightly different. They're not the same as the SF instruments in every respect. The Health Utilities Index comes with a user fee, and the Quality of Wellbeing Scale comes with a user fee as well. Translation. So one of the things that we were interested in, we did this work in British Columbia to inform policy in British Columbia, so we wanted to look at coverage from a translation point of view in terms of the languages that are most commonly or most frequently spoken at home in British Columbia, and then we added French to that list as well. Because it's not one of the most commonly spoken languages in BC, and you'll see that the EQ5D and the SF instruments are the most widely translated instruments. And then just on other instrument features, so this is then to do with the performance of the instruments in relation to decision making. So we made a judgment that in order to be useful in a decision making context, then it would be helpful to have utility scores. So this would then allow the conversion of any data that was collected using the PROM instrument into a utility scale. So for example, we could get quality adjusted life year estimates from such instruments. So in terms of those that are available with a utility tariff, then most of the instruments have a utility tariff. The Nottingham Health Profile and the WHO instruments are the only two that don't. The PROMIS has a conversion to a utility scale at this point. But those that have a Canadian utility score is just the EQ5D and the Health Utilities Index. The second aspect was to do with population norms, and those instruments, all of the instruments have population norms, but only 3 have Canadian norms, and that's the EQ5D, the SF36, and the Health Utilities Index at the moment have that. And then we also wanted to look at decision-making criteria that related to some sort of indication of a minimally important difference from a clinical perspective. And so we have many of the instruments have some indication of what a minimally important clinical difference is, and that could be used in decision-making as well. Okay, so I'm going to pass back to Rick, and we're going to talk about the research we did, the literature search we did in order to look at the psychometric evidence on these instruments.
So, and I'm going to keep it quite brief because I am conscious of, because we started a bit late. The details of this information are, of course, available in the report so that you have access to. So what I'm going to be talking about here is available for, is on page 32 onward in section 4B. So there's a lot of details, and I'll just provide you a general overview here. So in addition to those descriptive characteristics of prompts, we also need information about their validation, their validity, for the purposes to which we want to apply them. And so the framework of the review was structured approximately like this. So we've specified our purpose, which was to examine the evidence of measurement properties, psychometrics. And then the main point here is that we focused on a review of review articles. This was a critical decision point because this was an expedited knowledge synthesis, and it had to be delivered within a certain time frame so that it could be taken up expediently. And so we decided to focus on review articles. So reviews articles that involved information of psychometric properties about the instruments. And also we focused on those review articles that address a general population context. So we excluded articles that focused on a particular disease condition or a particular context. Then we did a comparative analysis, and what we used the Cosman checklist to guide us in this analysis. So Cosman is consensus-based standards for the selection of health measurement instruments, and has a whole checklist about the various categories of reliability and validity and so forth that one can then rate. And we had 2 independent raters completing that task, and then their scores were compared. And then where there were discrepancies, a consensus was reached as to what the most suitable rating would be. The review of review basically involved those 9 instruments. We searched the Medline and Embase databases, as well as we did a search of gray literature. And this kind of outlines how we ended up with a selection of 22 reviews of 8 instruments. You'll notice that the promise is not mentioned here, but it was included because there wasn't actually a review of that particular promise scale available. So in terms of the summary of the evidence, now this is a pretty dense slide, and so I'm not going to go through it in too much detail, but these are kind of the categories that the Cosman checklist evaluated. So that involves internal consistency, so coherence amongst the questions being asked, measuring the same construct. So it includes evaluations of internal consistency, Cronbach's alpha, and unidimensionality. We see, for instance, that the SF36 and the promise performs very well there, and there was limited information or inconsistent information on the EQ5D and the HUI and the quality of well-being scale. Then there's the reliability, so that has to do with test, retest, and interclass correlations and so forth. And again, the SF36 stood out there. Now, this is in terms of what is reported in the reviews, so we got to keep that in mind because that was the scope of our project. There was no evidence in reviews on PROMIS, WHO, QOL, and the AQL measure. And there was conflicting evidence on the EQ5D, the HUI, and NPH, NHP, I mean. Then there's the context validity of the instruments. So most instruments were fairly comprehensive, but there was diversity in that area as well. So the PROMIS instrument and SF36 really stood out in that area, as well as the WHO QOL. And then there's the construct validity. Do the scores represent the construct well? So one of the criteria is the explained percentage of explained variance in the construct being measured. And again, the SF36 and the PROMIS stood out well, as well as the WHO quality of life instrument. There's cross-cultural validity. It's a very important consideration, especially in BC context and well, Canadian context in general. So that has to do with validity assessments in multiple languages and across different cultural contexts. And the WHO was specifically developed for this purpose. So the WHO quality of life instruments obviously stands out, and the other instruments didn't really address this purpose explicitly that well in the reviews that we reviewed. There's criterion-related validity, so that has to do with the comparison with some gold standard. The challenge here being that obviously there isn't a particular gold standard on a PRO instrument, and so what we looked at in terms of what were the most dominant instruments that were being used for comparison purposes, and those were the SF36 and the EQ5D. And then finally, there is responsiveness, so the ability to detect change and also comparisons with changes in clinical outcomes or groups. And most of the evidence there was again for the SF36, the AQUAL, and the PROMIS. And there was actually some negative evidence there for the EQ5D and the NHP, so which is not surprising, especially the EQ5D being a very short instrument, and so shorter instruments are likely to be less responsive. So let's move to the next slide. Yeah. So this slide provides kind of the summary of the key strengths of weaknesses that we then brought to the workshop together with all of the other information, of course, to help guide the decision making. And so Sterling will describe us to which instruments actually received most of the attention then in the workshop, or were kind of highlighted in the workshop. So I'm not going to go through all these strengths and weaknesses in detail. You could read them in the report. But again, the SF36 did stand out as a top instrument in terms of psychometric properties, and one that is widely used in multiple cultural contexts, and many versions are available. And you could read about the other instruments here as well. I think I'll move on for the sake of time. When reviewing the evidence, there are some limitations, of course, to keep in mind. And one is that we did focus on a review of reviews. You can imagine that there are thousands of articles out there on that involve some psychometric information on these instruments. And so with an expedited knowledge synthesis, a decision needed to be made. And so we focus on a review of reviews based on the premise that a review is, of course, a strong source of evidence that already has done a level of synthesis. It's high up in the evidence hierarchy. But there are limitations, of course, with this. One being that there is some limitation in scope, in that there may have been validation studies, especially more recent validation studies, that have not yet been captured in reviews. And so implicitly, this preferences older instruments. One other thing to point out is that not all articles, like all articles, were classified as reviews, but they were not all necessarily systematic reviews. And so there was diversity in terms of the quality and the nature of the article. We did have a quality assessment form that was completed by 2 raters and compared, but that is important to keep in mind. Some reviews were more specifically focused on a particular instrument, whereas others were more focused on the comparison of multiple instruments. So on to you, Sterling.
Great, thanks very much. So one of the other things that we tried to do in a non-systematic way, so I wouldn't want to claim that this was a table that provided examples, all examples of use of PROM instruments in Canada or internationally, but we wanted to just give a flavor or a sense of where some activity was happening and what the focus of that activity was, and also what instruments were being used. So in Alberta, there's activity going on, and we see the EQ5D, the SF12, and the health utilities instrument being used both in primary and secondary care in Alberta. In BC, actually Rick and I are working on another CIHR-funded project looking at outcomes and experience and satisfaction in knee arthroplasty, and we're using both the SF12 and the EQ5D in that study. And at a regional level in Vancouver Coastal, there's quite a large project going on elective surgery. So we see other examples of instruments that are being used. One thing to highlight, I think, is the CCHS, the Canadian Community Health Survey, that has been using the Health Utilities Index and also the RAND instruments. It's probably one of the things that came to our attention was that Medicare in the US has now decided to focus its PROM activity using a modified version of the SF12, which is actually called the VR12, which is actually an instrument that has been developed by the Veterans Administration and is freely available for use, but is a modified version of the SF12. Okay, and then to the final part of our work was to present a workshop, or to hold a workshop. We did that in Victoria in the middle of January this year, and we had participants from across the province, mainly ministry and Michael Smith Foundation colleagues, but also people who were working in the health authorities as evaluators and as policy folks. We ended up choosing possibly the worst day from a weather point of view, and so flights were cancelled trying to get just from Vancouver to Victoria. So we ended up with some challenges, but most people who needed to be there got there, and so we had a good discussion. So the objective of the workshop was to share the details of the review and the synthesis work that we had done, to encourage some reflection and deliberation on the instruments and their potential use, specifically in the context of this IPCC, which is the Integrated Primary and Community Care Initiative going forward. So we also heard about some of the projects under the IPCC banner that were going forward in BC. So we gave people an opportunity to reflect and deliberate on what they'd heard in relation to the PROM instruments and how they might think about applying those PROM instruments in the context of IPCC. So we tried to put these together, and the objective was to try and come up with a consensus statement on which PROM instruments or instruments should be recommended for use in British Columbia. So the way that we did that, we actually had 2 rounds of voting and discussion at the workshop at the end of the session, where information was presented, and people had an opportunity also to review the instruments by actually we presented the actual hard copy of each instrument. One of the challenges with this work is, of course, that some of the instruments are copyright, and we've got to be careful about circulating the instruments because people have ownership of the instruments, and so not all of them are freely available to share, but we were able to share all of the instruments, and so people could see them. In the end, we had a vote that gave a strong preference for 2 of the instruments, so the PROMIS instrument and the SF family of instruments were seen as being the ones that people had a strong preference for, but also the EQ5D, people wanted to keep that certainly as a backup because of its shortness and its simplicity. So that's where we got to in terms of a recommendation of for going forward with British Columbia. There was interest in those, primary interest in those instruments. Good, and that brings us to the end of the presentation.
Thank you very much. Now I will pass the mic to Barbara to discuss policy implications. You may go ahead.
From the Ministry of Health, we really want to thank and appreciate the fine work that was taken by the research team. This funded knowledge synthesis has provided us with a very useful piece of evidence that it will shape BC's approach to looking at PROM. Moreover, it really stimulated our challenge to think through issues that we've not yet addressed, and I talked before specifically about what is our provincial strategy of how do we look at all patient-centered measures. For more than a decade, BC has been collecting data on patient experience, and we need to understand how that works into this. The other part is that we need to look at how this links with BC's participation in the Canadian Community Health Survey, as well as we're undertaking under the BCMA a number of...
Hi, Barbara. Apologies, it's Chad again. Is it possible for you to speak a little louder again?
Do I need to repeat what I said, or?
No, you make it, keep going.
Okay. The other part for us is that we, the physicians in BC, are undertaking a lot of satisfaction surveys, and we need to figure out how we can link that in. I think one of the key outcomes for this that probably was, thought we would, but it was really surprising knowledge for us, that it provided us with a very stellar process to aspire to on how we deliberated and the rigor that we went through to accompanying the tool selection. It involved all aspects of the province, and really a slice through the whole provincial health system got involved in us looking at those tools. The other part is that it really made us think about that we have to really balance the benefits of the outcomes and the use of the data, and how that can outweigh the burden either to the patient or the system in collecting that data. We do have examples where we have, in that last decade of collecting PREMS data, and we have not always made good use of that data. So we have to be very conscious of how we can move forward with this. So the project is now essentially complete for BC, and it's only starting our journey now towards how are we going to approach the implementation and in the integration of the PROMs on a province-wide, and that's the approach that BC wants to take, is try to look at a province-wide approach to improve it, and still guided by the triple aim work. So I think I'll stop there. So I think there are some questions, you know, that we could kind of ask the group. Has anybody else kind of looked at how to integrate that whole plan for patient-centered measures, and then as well as looking at different tools and different processes? So thanks.
Thank you, Barbara. So I will be moderating the questions. If you do have questions, I will ask you to actually click on the raise your hand button, or you can also chat your question into the chat box, but I would ask you to send your questions to all participants to make sure that everybody can see it. So does anybody have any questions that you would like? Just go ahead. So Cheryl Cott has a question. I will pass you the mic.
Oh, okay. Sorry.
So you may go ahead.
All right. Sorry about that. My question is, to what extent were consumers involved in choosing the final 3 measures?
So I can start on that one if you like. So we had, in British Columbia, there is a Patient Voices Network, and people from the Patient Voices Network were asked to be part of our workshop. So all of the information that was shared and the voting that happened included people from that network, as far as I can remember. But the ministry may want to clarify that.
I remember that we did invite the patient partners under the Patient Voices Network, so they were present on that day, and that's how BC has formally used that group to engage consumers into making healthcare decisions and policy decisions.
I do think it's a very important issue. I mean, you know, part of, as Rick was saying at the very outset, part of the objective on this and the underlying premise here is that the views of individuals receiving care should be central information that guides development of service. So the issue about how we most effectively elicit that information needs to be informed by not just policy folks, but by patients and citizens themselves. I fully agree.
Can I make another comment?
Sure, you can go ahead.
Sorry. Yeah, I'm not entirely convinced that patient-reported and patient-centered are interchangeable terms, and so I'm interested in the issue of identifying patient-reported outcomes that are important to patients, and not. I mean, I know it's important to look at reliability and validity, et cetera, but at what point do we get patients involved saying, yeah, this is important stuff, and I would be interested in having this information collected?
Yeah. So I mean, one of the things just to highlight that we haven't mentioned is I think pretty much all of the instruments that we had on our shortlist, the way that those instruments were originally developed was by, for example, discussing in focus group contexts or in interviews contexts what issues matter to people. So it's not imposing a structure in terms of the questions or the items that are being included. It's actually trying to gather information from individual patients and citizens about what aspects of health and health-related quality of life are most important and therefore should be captured in a routine way if we're going to be creating an instrument. Rick's probably got some thoughts on that.
Well, yeah, and I think this is a key consideration. So, but indeed, the instruments typically, most of them have been developed with quite extensive patient input. But the challenge is always with these type of systems that we're trying to get something that is generically applicable. And so that doesn't mean necessarily that it feels equivalently applicable to every individual patient. And I think that there's quite a diversity in terms of different contexts and the type of domains, and type of questions that patients that are more suitable for different patients. And one area of development that I'll just point out there that is actually meant to, in part, address part of that issue and of addressing the challenge of patients, avoiding that patients be exposed to questions and items that are really not that suitable and appropriate for them, is the work being done on computerized adaptive testing systems, which are also developed with patients' input. But they basically use large item banks of questions and use a statistical algorithm to figure out which questions are most likely to be most informative and most applicable to an individual given their response to a previous question or previous set of questions. Mm-hmm. And so there is that tailoring that tailoring mechanism built into these computerized adaptive tests. But the kind of the fixed form instruments, so this standard set of questions, there's going to be variability in terms of which patients or which people find them to be more or less suitable. So it's an ongoing challenge for sure. Mm-hmm.
Okay, thank you. So we'll move on to one of the questions that were submitted by chat by Rebecca. How might prompts be used in infants and children or other people unable to complete surveys?
Yeah, it's a great question. So, I mean, for this particular project, we focused on adults and not children. But I mean, we know from other work that we're involved in that clearly there are instruments that have been developed specifically for different populations that are below, say, the age of 18. So there are youth versions of instruments, and there are also pediatric or child versions of instruments. And obviously, you get to a point where you ask the question about who's the most appropriate person to be completing the instrument. So typically in young children, then a parent or a guardian typically responds as a proxy rather than the child themselves. But there do exist instruments that are specifically designed for pediatric and youth populations. Yeah, we excluded those from this work because our focus was on adults. I mean, you also have at the other end of the spectrum, of course, age spectrum, people who have cognitive impairments and cognitive challenges, and then you've also got an issue about who's the most appropriate person to act as a proxy for providing this information. Rick, have you got any thoughts on that?
Well, indeed, it's kind of a branch of patient-reported outcome measures that focus on the administration of these measures using proxies, and that does require a separate validation process. And some of the instruments that are listed here actually have a proxy version or a interview administrated version. So the ideal, of course, is that the measures are administered directly to the patient and answered by the patient, but that's not always possible. Now for kids, and actually also for adults, some of the instruments have alternative scoring mechanisms that use visuals like happy faces or sad faces and those kind of things instead of words. So there are adaptations of some instruments for those kind of purposes, but they've not been included in this review.
Thank you very much. We received a question from Kisa. With the stakeholder decision, what criteria played the most important role, was the most persuasive in the final decision of the three instruments?
So we haven't formally analyzed that, but so I'll give you my impression, and then others might want to add. But I think that the validity and the psychometric properties of the instruments were very important in guiding the selection of the instruments. The issue about burden and administration challenges in the instruments, I think, were also important, but I think primarily the issue of the validity. It was quite a strong emphasis on making sure that what we've got, or what we would be using, would be a valid and reliable measure. Barbara, you might have views. You were there.
That a tool that could address the broad range, and a significant one was making sure that it would address the mental health and substance use population, as well as looking at cultural or language was important for us. So I think that those were the biggest factors, and that's because we weren't, some of the other situations in which we've used it has been quite narrow. It's about a surgical procedure, versus this one we were trying to look at all community care, so trying to get one so it was the one more swayed towards something that was broader, more encompassing.
As I recall, as Rick here, one of the discussions or challenges was indeed that broad range of types of services and contexts that these instruments, that we wanted to apply these instruments to, and there was recognition that for some of these purposes, a more disease or context-specific measure might be more appropriate or important, an importance addition. And so there was a recommendation, it's also in our report, that for some of these contexts, probably kind of a generic PROM needs to be used hand in hand with a PROM that is appropriate or more sensitive to that particular context. The other thing that we did is everybody was actually encouraged to read that we put the items, the actual survey questions, on a display, and so everybody was encouraged to read them. And I think that also influenced people that as you read through the items, does it actually does it resonate?
Thank you. So we have time for maybe one more question. So there's a question from Corinne. I'm interested in the distinction between PROMs and PREMs. Given that quality is a central part of Ontario's and other jurisdictions' focus, which addresses the quality issue best? And then there's also a second parter, and how do we link the system and patient issues to determine true quality of care?
How long have we got?
About 7 minutes.
Yeah. I mean, I personally think that one of the benefits of this project has actually been to force consideration explicitly about PROMs and PREMs, so the experience measures and the outcome measures. And I think the consensus amongst the team, including our ministry partners and Michael Smith, was that we see value in both aspects of that information, and they're not necessarily competing. And if anything, we want to be thinking about the complementarity of the outcome question that is a patient-reported measure, and also the experience and satisfaction with the service. One of the challenges comes, I mean, we're actually thinking about how do we actually implement that, is that the experience questions typically relate directly to receipt of service. So it's asking about the experience of an interaction with the healthcare system, whereas the PROM measure is not linked, or doesn't have to be always directly linked to receipt of service, and so can be a broader question. So for example, in the CCHS, then there are PROM instruments because it makes sense to ask people generally about their health-related quality of life at this point in time, and it doesn't have to be linked directly to receipt of service. But my view is very strongly that these should be complementary, and that we should find ways of bringing them together and using them to provide a full picture of the experience patients receive.
I would agree with that, and also like the PROMs outcomes actually provide some context for helping to understand the PREMS scores. So evidently, there's some correlation between the two in terms of some people that have less desirable outcomes are also going to be less likely to be satisfied. And so that intersection between the two is a very important area of investigation, I think.
Thank you. I just wanted to add a note that everyone is encouraged to provide suggestions or ideas of topics for future IHSPR policy rounds. So feel free to just provide your comments and your ideas into the chat box, and we'll try to leave the session open for as long as we can after we're done.
Okay, I see that there's a question. Can I just ask specifically, quickly, say that there are electronic versions of many of these instruments, not all of them, but we have got information on the electronic versions that are available. So we can provide that if it's not clearly available in the report.
Mm-hmm.
Thank you. And I'll just provide a reminder that the questions that were not answered or that may not be answered we will actually follow up with you after the fact, after the session. So I guess we will move on to the evaluation, to the discussion of the evaluation. So we will be sending you shortly, well actually tomorrow, a short survey to be completed online to discuss this session, and we'll also send you a copy of the slide deck for you. So we will ask you to take some moments to complete this survey. And if you have any other questions, I will provide you with a list of contact information. So feel free to get in touch with either Sterling, Rick, Barbara, or Jennifer if you have any questions about what was presented to you today. And once again, thank you very much for participating, for your patience, and have a great day.